In this video, I'm going to discuss symptom management in multiple sclerosis. And as you can see from this list, people with MS experience a number of different symptoms.
When working up a possible MS exacerbation, it's a good idea to rule out a pseudo exacerbation, which is a temporary worsening of symptoms that often comes from an infection such as a UTI, overheating, or Uthoff phenomenon, which can occur with as little as a 1-degree increase in body temperature, or can occur from fatigue or other transient stressors. The management of a pseudo-exacerbation is to address its underlying cause.
Fatigue is the most commonly reported MS symptom. It's important to look for other causes of fatigue besides MS-related fatigue, such as infections. Sometimes an MS attack will present with fatigue. People with MS commonly have sleep problems that can cause fatigue or depression. Once those secondary causes are ruled out and you know that the person has MS-related fatigue, you can use various medications that are effective, such as modafinil, amantadine, formamipyridine, or a commercially available amphetamine preparation. Depression is common in MS, and it's important that we recognize it so we can treat it and refer people for support services. And when we think about depression, I think it's also important to think about screening people with MS for abuse and neglect, particularly people living with advanced MS who are at higher risk of abuse and neglect. Sexual dysfunction is another concern that people with MS sometimes experience, and it's important, I think, for us to ask about it even if patients themselves don't bring it up. Depression in MS differs from normal grieving. People with MS are at increased risk of depression compared to the general population, and compared with people with other similar disabling conditions. And 50% of people who have MS will experience a major depressive episode at some point over the disease course. So depression in MS is underdiagnosed and undertreated, and we can be part of the solution by diagnosing and treating it. Cognitive impairment is another important issue in people living with MS. I wanted to point out some common misconceptions. For instance, that cognitive impairment is rare in MS, or that it only occurs in people with advanced MS. Memory problems are actually reported by people living with MS very early on in the disease course. Not in everyone. 40 to 50% of people with MS will experience cognitive problems, and the rest don't. But these problems can occur early on. And it's good to bring up cognitive issues. It doesn't upset people with MS and their families in general that we do bring up the issues, and sometimes it's a relief for them to be able to talk about the problem. Cognitive function correlates with several factors on brain MRI, like lesion load and the amount of brain atrophy people are experiencing. And an MS exacerbation is a risk factor for developing additional cognitive dysfunction, so that's one of the types of residual disability we can try to prevent by treating exacerbations promptly. And it's also important to rule out pseudo cognitive issues that are actually caused by depression and treat those. Pain in MS is often neuropathic in origin. When someone with MS presents with pain, like with other presenting complaints, it's important to rule out secondary causes like an orthopedic issue that needs to be treated in another way. But once that's been ruled out and you know that it's pain related to the MS itself, it's often amenable to treatment. Not so much anti-inflammatory medications or narcotics, which I don't think are very helpful in this situation, but medications that are more targeted to neuropathic pain, like gabapentin or pregabalin. Spasticity can actually cause pain. It can impair gait, and it can impair sleep and be quite bothersome to people with MS. It's important, especially in people with advanced MS who experience new spasticity, to rule out an infection, because this can be a cause of new onset spasticity, like a urinary tract infection, as can an MS exacerbation. And there are a number of medications that can be helpful for spasticity, including baclofen and tizanidine. Tizanidine can be a little bit more sedating than baclofen, so you have to increase the dose very slowly and start at a low dose. Botulinum toxin injections can be helpful if spasticity is severe, and if it's very severe, a baclofen pump can be implanted. Vision problems are commonly experienced by people living with MS. First of all, visual sensory problems, optic neuritis is the prototype, causing blurry vision in one or both eyes. This is, sometimes presents as complete loss of vision in one eye or both, and is obviously a neurological emergency, requires referral and intravenous steroids according to the optic neuritis treatment trial. Visual motor problems occur as well, commonly causing diplopia or double vision. Bladder and bowel dysfunction are important issues to address, and I screen for these in office visits with patients living with MS. I tend to divide the bladder issues into failure to store versus failure to empty, and as you can see from this slide, there are specific treatments for each of these general categories of bladder problems. When we're addressing bladder problems, it's important to look for detrusor sphincter dyssynergia and for neurogenic bladder, and to anticipate these issues as they start to develop, because people need to be referred early to a urologist in order to manage their more severe bladder issues before they develop kidney damage. They may benefit from intermittent self-catheterization to prevent infections and renal damage, and there are actually special coated catheters that can be used with one hand if people have fine motor problems. Constipation is common in MS and amenable to treatment, starting with simple interventions like increasing fiber in the diet, fluids, exercise is very important, and then moving on to bulk forming agents or sometimes medications such as lactulose if need be. Swallowing impairment is an under-recognized issue that causes symptoms in people with MS, and they sometimes benefit from thickened liquids or from referral to a speech therapist for swallowing therapy. Headaches are more commonly reported in people with MS than in the general population, and can be treated as we treat headaches in anyone else. And I often see patients complaining of vertigo who have MS, and I find that low-dose oral meclizine can take the edge off the vertigo without being too sedating. Heat sensitivity is quite common. Even a slight elevation in body temperature, for instance, 1 degree elevation in body temperature, can cause a temporary worsening of symptoms that can be thought of as a pseudo exacerbation of MS, or Uthoff's phenomenon. And many people who live in warmer climates, who live with MS, have learned cooling strategies that they find helpful. For instance, there are cooling vests and other cooling garments that you can purchase, or people often prefer to exercise in water, like water aerobics or swimming, to keep cool. And finally, I wanted to address mobility issues for a moment and talk about various types of adaptive technologies available, ranging from canes to walkers to wheelchairs and scooters. One important point, I think, is to get the durable medical equipment prescription right the first time if possible, because it's easier to get prescriptions for assistive devices approved the first time rather than to get revisions approved. There's a difference between ambulation and mobility, so even if people can't walk, they can still be mobile and independent. So the goal of treatment is to promote function, comfort, and independence, using mobility aids as necessary to conserve energy, to enhance people's safety, and allow them to remain active and involved in their lives at home and outside the home. So in addition to the adaptive aids I mentioned before, I wanted to highlight the ankle foot orthosis, which is an underused adaptive aid that can be prescribed, isn't terribly expensive, and can be very helpful for someone who has a foot drop in terms of improving their gait. And finally, dalfampridine, or Ampera, is an FDA-approved medication to improve walking speed, and actually also helps people walk farther and more comfortably, and is not an MS disease-modifying therapy per se, but many patients find it very helpful. there are many resources available to people living with MS, their families, and their providers to enhance their care, including multiple sclerosis centers, the National Multiple Sclerosis Society, which is a wonderful website, therapy teams, physical therapy, occupational and speech therapy, physiatry, urology, ophthalmology, psychology, and various school and community-based programs. And finally, we hope that if you would like more assistance, that you reach out to us at the Connect MS program. You can call us at 805-652-6255. This is a new program that is funded by Genentech and provides telemedicine consultations for people living with MS in the Central California Coast region. Thank you for participating.